Hello friends, today we are discussing about the case of methicillin sensitive Staphylococcus aureus and methicillin resistant Staphylococcus aureus and treatment. So we have this 62-year-old male patient who is a known case of psoriasis, benign prostatic hypertrophy. Now came with chief complaint of headache, altered mental status since 1 month, and CT brain was done, which showed hyperdensity, measuring approximately 6.3, 3.6 to 1.6 centimeter, with surrounding large area of the hypodensity is noted in the temporal region involving both gray matter and white matter. So we have treated since the size of the bleed was small, we have treated conservatively. The hematoma was present on the left hand, and the blood culture was showed. Blood culture was sent for this patient, which showed methicillin sensitive Staphylococcus aureus. So this was so we have started this patient on cefazolin. Our next case is 22-year-old male patient with no known comorbidity. He started complaining of abdominal pain, multiple episodes of loose motion, and vomiting. He has taken medicine for the same on OPD basis. Then started complaining of the pain on the shin of the leg, and which was progressive in nature, and it was associated with swelling. It also involved knee. He started developing rash next day, taken medicine but did not relieve. So he got admitted. So here we did this USG of leg with Doppler, which showed bulky pectineus and adductor muscle on the left side, showing diffuse edema with irregular multiseptate collection. And it has also shown a 9.3 into 4 into 2 centimeter size irregular shape large collection in anterolateral aspect of the calf on left side. Then mild subcutaneous edema was noted, and there was no any evidence of the DVT. Then we did this MRI of the hip, which showed the left iliacus, pectineus, adductor muscle, appeared bulky and showed the diffuse edema with the irregular multiseptate pockets of the fluid within, as and there was a loss of intraluminal signal void within the left superficial femoral vein, which was and rest, which was been squarey intraluminal thrombus was there, but our Doppler showed no evidence. So we have further we have sent the blood culture for this patient, which showed growth of Staphylococcus aureus, which was which was MRSA. And this patient required means 4 liter of O2. So we did CTPA to rule out acute pulmonary thromboembolism, but CTPA showed no pulmonary. Started this patient on Clexane, and for MRSA we have started this patient on the Targocid. So now we have two bugs, that is methicillin. Just now we have seen the case of two bugs, that is methicillin sensitive Staphylococcus aureus and methicillin resistant Staphylococcus aureus. Now we will see how to evaluate these cases and how to treat. So there are two type of MRSAs, like community acquired MRSA and hospital acquired MRSA. So risk factor for community acquired MRSA is close household contact with those colonized with MRSA and community acquired MRSA infection. Those who are living in the overcrowded situation like military prisons and the overcrowded homes have had repeated skin traumas like athletes, military recruits, belong to certain ethnic group, that is Native American, Pacific Islanders, Africans and Americans. And those who have had exposure to healthcare system like office visit in the past year, antibiotic in past year, work in healthcare field, engage in high risk behavior, that is IV drug user, men who have sex with men, our children, young adults, go to daycare centers, or those who are homeless, have close contact with the colonizing pets, immunocompromised, including patients with HIV. Then hospital-acquired MRSA, the risk factors are recently hospitalized person, have had recent medical procedure, have had been treated in long-term care setting. Then hospital-acquired MRSA is associated with multi-drug resistance. Now, what is the exactly difference between the healthcare associated MRSA and community acquired MRSA? So, type of infection, it is healthcare associated MRSA is predominantly skin and soft tissue infection. It is usually multi-drug resistant, and it carries the type 1, type 2, type 3 SCC make gene. It usually do not carry the PVL gene. But the community acquired MRSA is associated with a deep seated and systemic infection. It is often susceptible to the non-beta lactam drugs. They carry the type 4 and type 5 SCC make gene, and it typically carry the PVL gene. So Staphylococcus aureus bacteremia is one of the most morbid infectious syndrome, and it is a leading bacterial cause of death worldwide. Traditionally, the Staphylococcus aureus bacteremia has been described as complicated and uncomplicated. So what is uncomplicated Staphylococcus aureus bacteria? That means when we have excluded endocarditis, there is no implanted prosthesis. Negative follow-up culture, the cultures are negative during the follow-up days at 2 and 4. Then defervescence within the 72 hours of antibiotic, and there is no evidence of metastatic sites of infection. Then what is complicated Staphylococcus aureus bacteria? Complicated Staphylococcus aureus bacterial infection is if a patient is not meeting criteria of the uncomplicated, then it comes in the category of the complicated. It is generally accepted that the minimum evaluation of the patient with Staphylococcus aureus bacteria should include the following: a thorough history, physical examination, evaluating for the source like onset of symptom, injection drug use, presence of indwelling lines, evidence of skin soft tissue infection, and potential site of the metastatic involvement like cardiac, skin, and the osteoarthritis. Then we should involve the infectious disease consultation, then follow-up cultures we should taken, and we should do the echocardiography. Then what are the most important things in treatment? So if we are isolating Staphylococcus aureus from the blood, then please do not ignore it because it is not a contaminant. All patients with Staphylococcus aureus in the blood should be treated with appropriate antibiotics and evaluated for source of infection. Now the next thing is how if we are isolating the source, then how to control it. Then we should remove for source control. We should remove the infected catheters, prosthetic devices, retention of the infected central lines in the prosthetic devices in setting of Staphylococcus aureus bacteremia has been associated with the prolonged bacteremia, treatment failure, and death. So these should be removed if medically possible. Retention of the prosthetic material is associated with increased likelihood of Staphylococcus aureus bacteria relapse, and removal should be considered even if not clearly infected. So the second thing that we need to do is evaluate for the metastatic infections like endocarditis, osteomyelitis, and abscesses. Metastatic infections and the endocarditis are quite common in Staphylococcus aureus bacteria. So all the patients should have a thorough history taken and examination performed with any new complaint evaluated for possible metastatic infection. Then echocardiogram should be strongly considered for all patients with Staphylococcus aureus bacteria. Then all the patient with the prosthetic valve, pacemaker, and ICD present or persistent bacteremia should undergo transesophageal echocardiogram. Then we need to document clearance. Then we need to take the repeat cultures at 48 to 72 hours after initial positive culture to document clearance of bacteremia, as Staphylococcus aureus bacteremia may persist even when fever has resolved. Positive repeat blood cultures are predictor for metastatic or endocarditis and should prompt in-depth investigation for this condition. If repeat blood cultures are positive, then do not repeat more frequently than every 48 to 72 hours. Treat with right drug and right dose. Place the patient on the most effective therapy as soon as possible. So if our bug is methicillin sensitive Staphylococcus aureus, then use a beta lactam like oxacillin. 2 gram every 4 hourly is the preferred drug. If the infection is non-severe and if the patient is allergic to beta lactam, then we can go for cefazolin, that is 2 gram every 8 hours. If methicillin resistant Staphylococcus aureus is there, then we can use vancomycin routinely. The dose of vancomycin is 15 mg per kg every 12 hours. Do not change therapy based on vancomycin minimum inhibitory concentration. Patients who do not respond to therapy after 5 to 7 days may be considered for change to alternative agents like daptomycin. Then treat it for the right duration. Failure to treat Staphylococcus aureus bacteremia for adequate duration results in increased rate of relapse and trend towards increased treatment failure. The minimum treatment duration for uncomplicated Staphylococcus aureus bacteremia is 2 weeks and it is generally IV. The majority of the patients should receive 4 to 6 weeks of therapy. Involve infectious disease physician early. Studies have shown that ID involvement in the management of Staphylococcus aureus bacteremia is associated with improved detection of metastatic infection and adherence to the treatment guideline with the decreased relapse rate and mortality. Then in short, this is algorithm which showed the treatment of the gram-positive cocci. So patient with one of two blood culture showed positive for gram-positive cocci in clusters. Then we should divide this patient in two categories like clinically stable patient and clinically unstable patient. So first we will see what are we going to do with the clinically stable patient. So if the patient is clinically stable, then wait for a BCID result before starting antibiotic. If our BCID result shows Staphylococcus aureus uh, positive, then we need to wait for if it is a make A positive or a make A negative. If it is a make A positive, then we have to treat it with vancomycin. If it is a make A gene negative, then we have to treat with oxacillin. If the BCID panel showed the Staphylococcus aureus negative result, then or a negative result, then we should not start any antibiotic. In case if there is a clinical worsening hypotension and second blood culture is positive for the gram-positive cocci in clusters, then again we need to evaluate for the make whether it is make A positive or make A negative. In case of make A positive, start with vancomycin. If it is a make A negative, start with oxacillin. And if patient is stable and only 1 to 2 blood cultures are positive, then no antibiotics are indicated. If the clinically in case of the clinically unstable patient, start vancomycin. Management of the Staphylococcus aureus bacteremia. Regarding methicillin-sensitive Staphylococcus aureus, studies have shown that treatment with the vancomycin is associated with increased mortality risk compared to the beta-lactam therapy, even when therapy was altered after culture results identified MSSA. So, convenience of vancomycin dosing does not outweigh the potential benefit of beta-lactam in treatment of MSSA bacteremia. So the preferred first line therapy is always oxacillin, 2 gram IV 4 hourly. That is or penicillin G for 4 million units every 4 hourly. While clinically equivalent should not be used unless the presence of inducible beta-lactamase has been ruled out by microbiology lab. Now, if the patient is allergic to penicillin, if the infection is non-severe, then we can start with cefazolin, that is 2 gram every 8 hours. MSSA isolates are considered susceptible to other beta-lactam, such as ampicillin, sulbactam, piperacillin, tazobactam, cefepime, ceftriaxone, ertapenem, meropenem. And there is a lack of clinical data supporting use of this agent in bacteremia, but in mixed infection they are considered active and addition of another agent such as vancomycin is unnecessary. So the third line therapy is we can use this vancomycin 15 mg per kg every 12 hours. The first line for severe penicillin allergy. So if it is MRSA, then the first line is vancomycin 15 mg per kg 12 hourly. Vancomycin should not be avoided based on the elevated but susceptible MIC values. Trough levels of 15 to 20 should be targeted, and consultation with the pharmacy is recommended. Then if we vanco, then our second line, if vanco, if we cannot use vancomycin, then go for daptomycin. Second line therapy is daptomycin. We can use it in the dose of 6 mg per kg IV every 24 hours. Then additional antimicrobial agents. The routine addition of agents such as rifampin, gentamicin is not recommended. Gentamicin use provide little clinical benefit and has been associated with increased nephrotoxicity even when only used for a short time. Rifampin use is associated with increased drug interaction and toxicity but doesn't have any role in infection where prosthetic devices are present, such as prosthetic heart valve, pacemaker, or prosthetic jaw. Rifampin should not be added without the input of infectious disease team. Rifampin should never be used alone as a resistance rapidly develops. Then the next is repeat blood culture in 48 to 72 hours to document clearance of bacteria. Positive repeat blood cultures are predictor of endocarditis and metastatic infection and should prompt in-depth investigation for this condition. Continue to repeat blood culture is no more frequently than every 48 to 72 hours until clearance is achieved. Now, if there is catheter and prosthetic device in situ, then how are we going to manage this? So, Staphylococcus aureus has many virulence factor which allow it to colonize and infect metal and plastic surface, and catheter and other prosthetic device are often infected by Staphylococcus aureus without any clinical signs of infection. So, if there is any prosthetic device or intravascular catheter present at the time of Staphylococcus aureus bacteremia, then it should be considered infected until infection is ruled out. An attempt should be made to remove all prosthetic devices. In one study, the retention of indwelling foreign bodies was associated with 18-fold increase in the risk of Staphylococcus aureus bloodstream infection relapse. Now, catheter management. If it is a short-term catheter, then all catheter present at the time of bacteremia should be removed as early as possible. If it is a long-term catheter, then the catheter should be removed unless there are major contraindications, like lack of alternative venous access, patient has significant bleeding diathesis, or quality of life issues take priority over the need of reinsertion of new catheter at another site. Now, other prosthetic material due to high rate of infection, even when asymptomatic, any patient who with persistent Staphylococcus aureus bacteremia should have all retained prosthetic material like prosthetic valve, prosthetic joint, pacemaker, ICD should be removed if possible. In such a cases, ID consultation is highly recommended. Removal is not always medically possible, and in these cases, consideration should be given to addition of rifampin and long-term suppression. Now, when to do echocardiography? So, echocardiography should be strongly recommended for all the patients with Staphylococcus aureus bacteremia. There is some debate over the routine use and type of echocardiogram in Staphylococcus aureus bacteremia. Some studies have suggested that patients with the low risk of bacteremia, known source which is rapidly removed on drain, then rapid resolution of fever, no repeat blood culture positive, no prosthetic valves or intravascular devices, no murmur on finding to suggest endocarditis. Then in that case, we can avoid echocardiography. Patients who do not clearly meet another above criteria should undergo echocardiogram. Then transesophageal echocardiograph is always preferred over transthoracic due to improved sensitivity for detection of endocarditis and identification of complications such as valve abscess and perforation. So TE is the test of choice in all patients with prosthetic valve, pacemaker, ICD present and persistent bacteria. If TE is performed, it should be generally be performed at least 3 to 5 days after onset of bacteremia to minimize the possibility of false negative results. Now, the treatment duration of Staphylococcus aureus bacteremia. The minimum treatment duration of Staphylococcus aureus bloodstream infection is 14 days, and duration of therapy is determined by the type of bacteria, whether it is complicated or uncomplicated. So in case of uncomplicated bacteria, treat at least for 14 days from negative blood cultures. And it should meet all the following criteria as we have seen in the no implanted prosthesis, negative follow blood culture obtained 48 to 72 hours after initial say, resolution of fever within 72 hours of initiating effective therapy, not immunosuppressed or neutropenic, removal of any involving catheter. It is unknown if transition to oral therapy is safe or not, but in patients with the low risk conditions like UTI, skin soft tissue infection without residual abscess who meet criteria for uncomplicated bloodstream infection, then we can switch to the oral agent with good oral bioavailability like trimethoprim, sulfamethoxazole, linezolid, and a high dose cefalexin. Then, in case of complicated bacteria, treat for 28 to 42 days from the negative blood culture with IV therapy, which is defined as patient with positive blood culture result do not meet the criteria for uncomplicated bacteria. Specific duration of therapy defined by complications described like prolonged bacteremia versus endocarditis, osteomyelitis, and written prosthesis. In case of complicated bacteremia, ID consultation is strongly recommended. Now, catheter tip culture positive only bacteria. Then what are we supposed to do in this case? While it is not recommended to routinely culture the catheter tips, but if catheter tip culture is positive for Staphylococcus aureus and the blood cultures are negative, then the patient should receive 5 to 7 day course of antibiotic along with close monitoring for signs and symptoms of ongoing infection. Now, in case of persistent Staphylococcus aureus bacteria, it is not unknown for Staphylococcus aureus bacteremia to persist for several days after initiation of appropriate antibiotic therapy and differences of the patient, like uh, 3 to 5 days. Metastatic foci and complication became more frequent in bacteremia lasting for more than 3 days. Failure to clear bacteremia should prompt evaluation for metastatic foci of infection. Now, the diagnostic tests that we should consider include TE, then CT of affected area, MRI of spine, TAG, WBC scan, PET scan, or CT scan. Testing should be based upon signs and symptoms of infection. Thank you.